Welcome to It's Your Case, presented by vetct.com. I'm Christina Meerhof, your radiologist on demand for this week. Today's example is a 1-year-old male neutered Rat Terrier with a 12 hours history of anorexia and vomiting. Once you have reviewed the radiographs using your systematic approach, then you're ready to watch this video. Now I will highlight the most important findings for this radiograph. The patient is rather slim with a reduced amount of intra-abdominal fat, so there's no fat really ventral to the liver. And I have a mild reduction of abdominal detail in the central abdomen. So the stomach is dilated with gas, but it is located in a normal position. We have a right lateral projection, which we need to differentiate a gastric dilatation from a gastric torsion. And we see in a right lateral projection, as it should be, the gas is coming up and highlighting nicely the fundus with a single gas bubble. There's also some soft tissue opaque material here in the stomach. If we have a look at the left lateral projection, the gas is coming up into the area of the antrum and pylorus, and as there's a lot of gas, there's also gas in the gastric corpus. There's soft tissue opaque material here in the fundus. In the VD projection, we see gas in the antrum and in the fundus, so the stomach is not torsed. There's also some gas within the descending duodenum, which is seen here. And some of the material in the descending duodenum, especially here in the left lateral projection, has a stripy appearance. This is very subtle, I have to admit. The remaining small intestines contain some soft tissue opaque material and a few gas bubbles. The colon contains a moderate amount of granular unformed material, can be followed here, and this is probably soft tissue opaque material and gas in the cecum here. We have an incidental old rib fracture of the 13th rib on the left side, which is an incidental finding. So our conclusions are there's a mildly reduced abdominal detail, we have a gastric dilatation and possible foreign material in the descending duodenum. The reduced abdominal detail could be caused by the body condition of the patient alone, or a small amount of intra-abdominal fluid or some peritonitis, especially in the central abdomen, cannot be completely excluded. The dilatation of the stomach could be caused by a proximal obstruction, by a gastritis, a motility disorder, or aerophagia, for example due to stress or pain. As a proximal obstruction cannot be clearly diagnosed because, as I said, this is very subtle, an ultrasound of the abdomen is recommended. Alternatively, in case the patient is stable, follow-up radiographs after 12 hours of prolonged fasting could also help to monitor the status of the gastrointestinal tract. Be sure to review the full report associated with this case. Thanks for listening, and remember, it's your case, so please post your questions on social media.